so in most of the cases, we see the spontaneous regression of this detachment. Okay, spontaneous regression that is seen in 3 to 6 months following the disease. Okay, so following the occurrence of the disease. Okay, so we need to reassure the patient. Okay, and we need to wait for 3 to 6 months for spontaneous recovery. Okay, if it is a large CSR, that is I told bullet CSR, and if it is long standing, that is more than 3 to 6 months, then and also if it is a recurrent CSR, and also if there is a history of loss of vision in the other eye, then we can go for laser photocoagulation. Okay, so what we do is it is only a focal photocoagulation which is done to the point of leak. Okay, we do the FFA and then we clearly identify the point of leak, and exactly to that point we do the focal laser. Okay, and then in other cases, like if it is not responding to the laser, then we can go for photodynamic therapy. Photodynamic therapy. Okay, so the complication in the CSR is the choroidal neovascular membrane is the complication. Even in myopia, we have seen that the complication in myopia is the choroidal neovascular membrane. Okay, so if there is choroidal neovascular membrane, definitely it should be treated with anti-VEGF drugs. Okay, so that is about CSR. Okay, then coming to the retinoblastoma. Okay, so retinoblastoma is the most common childhood intraocular tumor. Okay, most common childhood intraocular tumor, and it is seen in the incidence is 1 in 15,000 to 20,000 live births. Okay, so it is due to the proliferation of neural cells which have failed to evolve normally. Okay, proliferation of neural cells which have failed to evolve normally. Okay, so then coming to the etiology, so it is frequently congenital. Okay, congenital. So it affects the infants and very young children. Okay, infants and very young children. Okay, so it is bilateral in 25 to 30% of the cases. Okay, so the other eye is affected independently. Okay, so the other eye is affected independently. Okay, so it is directly associated with the genetic abnormality. Okay, then coming to genetics and heredity in retinoblastoma. So we have a retinoblastoma gene. Okay, so which is present on 14 band on long arm of 13 chromosome. Okay, 14 band on long arm of 13 chromosome, that is 13q14. Okay, so it is now, it is present there. Okay, so this retinoblastoma gene is cancer suppressor or anti-oncogenic gene. Okay, it is a cancer suppressor gene. Okay, so the retinoblastoma occurs when there is deletion or inactivation by two mutations. Okay, when there is deletion or inactivation by the mutations. Okay, two mutations, then the retinoblastoma occurs. Okay, and that is known as Knutson's two-hit hypothesis. Okay, so inactivation by two mutations. Okay, so that is known as Knutson's two-hit hypothesis. Okay, so overall, coming to the genetics and heredity, so 10% of the cases are familial. Okay, 10% are familial. So that is by autosomal dominant inheritance. Okay, 90% they occur sporadically. Okay, so that means 10% are hereditary, and then 90% they occur sporadically. That is by mutations. Okay, so we will see. So among these 90% of the sporadic cases, so 10% are inherited. Okay, okay. Then the rest 90 somatic there by the mutation. That is sporadically they occur. Okay. So among 90% of sporadic cases, 60% occur by somatic mutation. Okay, and then 30% by germline mutation. Okay. So these germline mutation cases are also heritable. Okay, so altogether, so 10% of familial cases, and then even these germline mutation cases, 30%. So altogether, 40% are heritable cases. Okay, so the non-heritable somatic mutation cases, okay, are 60%. Okay, so these heritable cases, some of these heritable cases, they have a trilateral retinoblastoma. Okay, trilateral retinoblastoma. Okay, trilateral means bilateral retinoblastoma plus pinealoblastoma. Okay, bilateral retinoblastoma plus pinealoblastoma is known as trilateral retinoblastoma. Okay, so the heritable cases, they transmit the disease by autosomal dominant inheritance. Okay, to 50% of their offsprings. Okay, 50% of their offsprings. Okay, so that is about the. Then coming to non-heritable or somatic cases, so 60% of retinoblastoma, they occur sporadically by both the hits. Seen, no, that is Knutson's hit hypothesis. Okay, so by both the hits, okay, occurring in same retinal cell in embryo after fertilization. Okay, they occur in the same retinal cell in embryo after fertilization. Okay, so these non-heritable or somatic cases are unifocal, unilateral, and they cannot pass on to the offsprings. Okay, unifocal, unilateral, and they cannot pass on to the offsprings. Okay, okay. Whereas the rest of the cases, the heritable cases are they may be bilateral and multifocal. Okay, so have you understood that basically the retinoblastoma gene is cancer suppressor gene? Okay, so because of mutations, okay, deletion of mutations, so that is Knutson's two-hit hypothesis. Okay, so there occurs, so in that occurs in sporadic cases. Okay, so 10% familial autosomal dominant and 90% sporadic, and among them 60% somatic mutation and 30% germline mutation. Altogether 40% heritable cases. Okay, and then and then, so heritable cases can be bilateral and multifocal, whereas non-heritable cases are unifocal and unilateral. Okay. Then coming to the pathology. Okay. So the retinoblastoma is due to malignant proliferation of the immature retinal neural cells. Okay. Immature retinal neural cells, which are known as retinoblasts. Okay. Then coming to the histopathology. Okay. The retinoblastoma cells are small round cells with large nuclei. Okay, so they may be highly undifferentiated or well differentiated tumor. Okay, so highly undifferentiated means it's a more dangerous disease. Okay, well differentiated is less dangerous disease. Okay, so in the well differentiated, we can see the cells which are arranged in different patterns. Okay, so there may be flex nerve intestinal rosettes. Okay, flex nerve intestinal rosettes or homoryte rosettes, pseudo rosettes, and florets. Okay, so flex nerve intestinal rosettes, homoryte rosettes, pseudo rosettes, and florets. Okay, so see, the retinoblastoma is a very fastly growing tumor. Okay, so because of its fast growing, so there will be the lack of blood supply to this tumor mass. Okay, leading to large areas of necrosis and calcification, which is a typical feature of retinoblastoma. Okay, so we can see that the flex nerve intestinal rosettes. Okay, we can see the columnar cells which are arranged around a central lumen. There is a central lumen surrounding that. We can see the columnar cells. Okay, that is flex nerve intestinal rosettes, also seen in medulloepithelioma. Okay, so homoryte rosettes. So around the central neuromuscular core. Okay, so the cells are arranged surrounding a central neuromuscular core. Okay, surrounding that we see the tumor cells. Okay, then the florets. Okay, so the tumor cells with pear-shaped eosinophilic processes. Okay, tumor cells with pear-shaped eosinophilic processes. Okay, that is a florets. Okay. Then coming to the clinical picture of retinoblastoma, so it is divided into 4 stages. Okay, so one is the quiescent stage. First stage is the quiescent stage, then the glaucomatous stage, then the stage of extraocular extension, and then the stage of distant metastasis. Okay, so first stage is the quiescent stage. Okay, so in the quiescent stage, so this occurs in 6 months to 1 year of age. Okay, so the child presents with leukocoria. Okay, so leukocoria means white reflex in the pupillary area. Okay, so white reflex in the pupillary area is known as leukocoria. Are you able to see that? See, this is the normal pupillary area, and this is, we can see that in the pupillary area we can see the white reflex. Okay, so this is otherwise known as amerotic cat's eye reflex. Okay, amerotic cat's eye reflex. Amaurosis means lack of vision. Okay, so loss of vision. Okay, so because of retinoblastoma, the vision will be lost. Okay, so amerotic cat's eye reflex. Okay, leukocoria is, you can see here also. This is the normal, and you can see the white pupillary reflex. Okay, so it is present in 60% of the cases. Okay, so the child can present with squint. Okay, that is the convergent squint. Convergent means medial deviation. Nasal deviation is known as convergent squint. Okay, so the child can present with nystagmus. Okay, nystagmus means involuntary eye movements. Okay, is known as nystagmus. It is rare, but is seen in bilateral retinoblastoma. Okay, and if the child is older, that is 3 to 5 years of age, he can present with defective vision. Okay. Then coming to the ophthalmoscopic exam, that is on fundus examination. So the tumor may be of 3 varieties. Okay, it may be endophytic, exophytic, or diffuse infiltrating. Okay, endophytic means the tumor, it extends into the vitreous cavity. Okay, that means endo means inside. Okay, inside into the vitreous cavity, that is endophytic. Exophytic means outside. Okay, outside the retina. Okay, it extends. Okay, so that means underneath the retina it extends. Okay, giving rise to elevation of the retina, leading to separation of the retina, that is leading to retinal detachment. Okay, diffuse infiltrating means along the plane of the retina it infiltrates. Okay, so it spreads, leading to thickening of the retina, plaque-like thickening in the retina. Okay, so 3 types: endophytic, exophytic, and diffuse infiltrating. Okay, so it grows into the vitreous cavity, and we can see well differentiated, that is well circumscribed polypoidal mass. Okay, well circumscribed polypoidal mass, which is white or pearly pink in color. White or pearly pink in color, and we can see the fine blood vessels on the surface of the tumor, and sometimes we can see the hemorrhage on the surface of the tumor. Okay, so if there is a calcification, then it gives rise to what is known as cottage cheese appearance. Cottage cheese appearance. So this is a multifocal, okay, retinoblastoma. Okay, endophytic retinoblastoma. Okay, then we can see multiple growths which extend into the vitreous with seeds into the vitreous cavity. We can see multiple tumor seeds into the vitreous cavity. Okay. So then coming to exophytic retinoblastoma, it grows outside, leading to, I told you, exudative retinal detachment. Okay. Whereas in diffuse infiltrating tumor, we can see the placoid thickness of the retina. So you can see here, this is the retina. Okay. So this is the endophytic tumor which is extending into the vitreous cavity. Okay. And this is the exophytic tumor which is proliferative underneath the retina. Okay. And we can see that the retina is detached. Okay. This yellow area is the detached retina. Okay. So this is the exophytic. Okay. So that is about quiescent stage. Then coming to the glaucomatous stage. Okay, so in glaucomatous stage, the patient complains of severe pain, redness, and watering. Okay, so there may be secondary glaucoma or intraocular inflammation. Okay, and then what are the causes for secondary glaucoma in retinoblastoma? See, the tumor, when there is extensive growth into the vitreous cavity, then it pushes the lens iris diaphragm forwards, okay, leading to the closure of the angular anterior chamber, okay. So leading to elevated intraocular pressure, okay, or the tumor cells can directly go and clog the trabecular meshwork, okay. So that can also lead to elevated intraocular pressure, okay. That is secondary glaucoma, okay. Then on examination, the eyeball it enlarges. Okay, so when the eyeball enlarges, that is known as ophthalmus. Okay, ophthalmus. See, if the child is less than 3 years of age, and if there is elevated intraocular pressure, then the anterior part of the globe it enlarges in size. Okay, but if the child is more than 3 years, okay, even in the adults, so we don't see any enlargement of the globe in glaucomas. Okay, so only when the child is less than 3 years of age, there will be enlargement of the anterior part of the globe. Okay, leading to ophthalmus. Okay, large eyeball. Okay, is known as ophthalmus, which is seen in congenital glaucomas. Okay, so even in this secondary glaucoma. Okay, then there will be proptosis. Proptosis means protrusion of the globe. Okay, then we can see the congestion, conjunctival congestion, as well as circumcorneal congestion, and we can see the corneal haze. Okay, due to raised intraocular pressure. Okay, so the retinoblastoma it masquerades as iridocyclitis. Okay, masquerading means it is mimicking. Masquerading means it is mimicking as iridocyclitis. Okay, so we can get the acute uveitis. Okay, so acute uveitis with the pseudohypopion and hyphema. Okay, what is hypopion? It is pus in the anterior chamber is known as hypopion. Okay, but it is not pus, so it is only due to tumor cells. Okay, so that is why they are known as pseudohypopion. Okay, hyphema is blood in the anterior chamber. So it can present as pseudohypopion and a hyphema. Okay, so that is about the stage of glaucomatous stage. Okay, then the third stage is the extraocular extension. Okay, so what happens is, I told you, so this is the pseudohypopion. The tumor cells in the anterior chamber is known as pseudohypopion, presents as hypopion, but it is pseudohypopion. Okay, and then in the extraocular extension, the globe bursts to the sclera. Are you able to see that there is a burst of the sclera? Okay, it may be near the limbus or at the optic disc area. Okay, so when it comes out, okay, there will be rapid fungation. Okay, with marked proptosis and with the involvement of the extraocular tissues. Okay, so that is extraocular extension. Okay, so where there is involvement of the even the orbital tissues. Okay, and then stage of distant metastasis. Okay, so that can occur either by lymphatic spread to the preauricular or neighboring lymph nodes. Okay, or direct extension via the optic nerve to the brain. Okay, or via the bloodstream, it can spread to the cranial and other bones and liver. Okay, so lymphatic spread to the preauricular lymph nodes and the neighboring lymph nodes, and then direct extension via the optic nerve to the brain. Okay, and then via the bloodstream to the cranial and other bones and the liver. Okay, and you can see that via the optic nerve, it has, so the globe is full of the tumor mass, and then even the optic nerve is involved, and it has extended into the suprasellar portion of the brain. Okay, suprasellar extension. Okay, we can see this is the tumor mass. Okay, so that is intracranial extension. Okay, so that is the distant metastasis. Okay, then what is the classification for retinoblastoma? Okay, so there are two different classifications. One is the international classification of retinoblastoma, and the other one is the Rees-Elsworth classification. Rees-Elsworth classification is a prognostic classification. Okay, then coming to international classification of retinoblastoma, it is divided into five groups. Five groups. Okay, so group A is the small tumor that is less than or equal to 3 millimeters in size. Group B is large tumor that is more than 3 millimeters, or from the macular area if the location is less than or equal to 3 millimeters from the fovea, okay, from the fovea, or juxtapapillary, that is surrounding the disc area, okay. The location is less than or equal to 1.5 millimeters from the disc, okay, and the subretinal fluid less than or equal to 3 millimeter from the margin of the tumor. Okay, so large tumor more than 3 millimeters in size with its location from the macula and the disc, and also the amount of subretinal fluid. Okay, then group C, focal seeds, that is retinoblastoma with subretinal seeds less than or equal to 3 millimeters from the retinoblastoma, or vitreous seeds less than or equal to 3 millimeters from the retinoblastoma, and both subretinal and vitreous seeds less than or equal to 3 millimeters from the retinoblastoma, that is the focal seeds. And then diffuse seeds, retinoblastoma with subretinal seeds more than 3 millimeters from retinoblastoma, and then vitreous seeds more than 3 millimeters from retinoblastoma, and then both subretinal and the vitreous seeds more than 3 millimeters from the tumor itself. Okay, and then extensive retinoblastoma, massive retinoblastoma with anatomical or functional destruction of the eye, and a neovascular glaucoma, opaque media from hemorrhage in anterior chamber, vitreous or subretinal space, and then invasion of the post-laminar optic nerve, choroid more than 2 millimeters, sclera and orbit, okay, and then anterior chamber. Then tumor touching the lens, and diffuse infiltrating tumor, phthisis or pleurithisis. Okay, so these are the 5 groups, okay, according to International Classification of retinoblastoma. Okay, then what is the differential diagnosis for retinoblastoma? So the differential diagnosis of leukocoria. Okay, I told you white pupillary reflex. Okay, so this was previously known as retinoblastoma was known as glioma. Okay, so the all the other conditions which are DD for retinoblastoma are known as pseudoglioma. Okay, pseudoglioma. So under pseudoglioma we have congenital cataract, and then coloboma of the choroid, and then retrolental fibroplasia that is seen in retinopathy of prematurity. All the detached retina, it becomes crowded just behind the lens. Okay, so producing retrolental fibroplasia. Okay, and then persistent hyperplastic primary vitreous, and then toxocara endophthalmitis. Okay, toxocara endophthalmitis, and then Coats exudative retinopathy. Okay, so these are the differential diagnosis for leukocoria. Okay, and then differential diagnosis of endophytic retinoblastoma. Okay, so the retinal tumors in tuberous sclerosis, okay, they are known as astrocytomas, is a differential diagnosis. And then neurofibromatosis is a differential diagnosis for endophytic. And then exudative choroiditis, okay, and then exophytic retinoblastoma. For exophytic retinoblastoma, it is the exudative retinal detachment which is produced by Coats disease, is a differential diagnosis. Okay. Then coming to the diagnosis. So how to diagnose a case of retinoblastoma? Okay. So we need to examine the child because these are the children. Okay. So we need to examine the child under charge general anesthesia. Okay. So we need to examine with indirect ophthalmoscopy to look for the tumor and the extent of the tumor. And also we need to measure the intraocular pressure and then the corneal diameter. Okay. Then we need to take the plain X-ray orbit, okay, where we can see the calcification in 75% of the cases. I told you, that there will be extensive necrosis in retinoblastoma leading to calcification, okay. And then, so on plain X-ray orbit, we can see the calcification, okay. And then lactic dehydrogenase levels in aqueous. Okay, so aqueous tap for lactic dehydrogenase should be done, and the levels will be raised in retinoblastoma. Okay, and then ultrasonography. Okay, ultrasound B scan. Okay, for the globe where we can see the extent of the tumor and also its invasion into the optic nerve. Okay, and then CT scan. Okay, CT scan, with the help of CT scan, we can know the extension of the optic nerve and also orbital involvement and extension into the brain. Okay, so we can do both the CT or MRI can be done. Okay, to know about the intracranial extension. Okay, then you can see that in ultrasound B scan. So there is a tumor mass with the hyperreflective icosphere. Okay. So this is due to calcification. Okay. Which is producing back shadowing. Okay. So extensive calcification is there. Okay. Then coming to the treatment of retinoblastoma, so it includes local therapy and then tumor destructive therapy and then enucleation and then palliative therapy. Okay. So first coming to the tumor destructive therapy. So when the tumor involves less than half of the retina and the optic nerve is not involved, then we can give primary systemic chemotherapy. Okay, when the tumor involves less than half of the retina and when the optic nerve is not involved, then primary systemic chemotherapy, then followed by any of the, I'm sorry, local therapy. So first one is local therapy. Okay. So local therapy is done with cryotherapy. Okay. Cryo means eyes application. So with the eyes application also we can destroy the tumor. Okay. So that is cryotherapy for small tumors which are anterior to the equator. Okay. So for the small tumors which are posterior to the equator, we can give laser photocoagulation. Okay. We can give laser photocoagulation. The other one is the other local therapy is the thermotherapy with diode laser. Okay, thermotherapy with diode laser. So with this, so much of heat is produced. So there will be destruction of the surrounding structures. Okay, so this is useful for small tumors which are posterior to the equator but away from the macula. But away from the macula. So that is thermotherapy with diode laser. And then the other local therapy is the plaque radiotherapy. Plaque radiotherapy, which is very effective against localized vitreous disease for elevated tumors when laser is ineffective. Okay, so for the flat tumors, the laser is effective, but for elevated tumors which are extending into the vitreous, okay, then we need to do a plaque radiotherapy. Okay, so the other modality is the external beam radiotherapy, which is useful for diffuse disease in only remaining eye. Okay, that means the other eye, if the other eye is already gone, okay, and if only one eye is remaining, and in that also if there is a diffuse disease, then we need to go for external beam radiotherapy. So the local therapy is the cryotherapy and then laser photocoagulation and then thermotherapy with the diode laser and then plaque radiotherapy and the external beam radiotherapy. Okay, so that is the local therapy. Then coming to tumor destructive therapy. Tumor destructive therapy is done when the tumor involves less than half of the retina. Yes. When the tumor involves less than half of the retina and the optic nerve is not involved. Okay. And the optic nerve is not involved. Okay, so we need to give primary systemic chemotherapy, then followed by any of the local therapy. Okay, so the chemotherapy that we give, the drugs that we give are like carboplatin and then vincristine and etoposide. Okay, and it is known as CVE regimen. Okay, carboplatin, vincristine and etoposide. Okay, CVE regimen that is for group A, B, and C patients. Okay, whereas high dose CVE regimen is given for group D patients. Okay, that is tumor destructive therapy. See, after giving chemotherapy, we can see that definitely the tumor is destroyed. Okay, and then enucleation. So enucleation is done when the tumor is more than half of the involving more than half of the retina and even the optic nerve is involved. And also when there is glaucoma and even the anterior chamber is involved. So enucleated with maximum length of the optic nerve. So enucleation means it is the removal of the entire globe. Okay, entire globe along with the maximum amount of the optic nerve. Okay, And we need to send it for histopathological examination, especially at the edge of cut end of the optic nerve. We need to send it for histopathological examination. Okay, so if the cut end of the optic nerve, we can see, if we see the tumor cells even at the cut end of the optic nerve, then in postoperative period, we need to order for radiotherapy, that is 5,000 rads of radiotherapy applied to the orbital apex, and also we need to give chemotherapy. Okay, that is carboplatin and then vincristine and etoposide with cyclosporine should be given. Okay, so this is about enucleation. Okay, and then the rest I will tell you afterwards. Okay, thank you.